Good day, class. Mr. Garcia here. Again, sorry for canceling today. Been dealing with some muscle spasms as well. Took a long road trip and it was in the mountains. Very stressful up there. But I will be back on Wednesday for sure. Just to let you know a little of what's gonna occur in the coming weeks. We do have a medications test that we want to get done with on March 31st. And today we're going to start chapter 4. Let's see here. So we've done medications, and that's just an ongoing process. Again, I would quiz myself on those. Let's see here. Study through those. I like going through PTCB because they separate them accordingly here. And let's do 10 questions real quick. Which medication may cause permanent stains in the teeth of small children who are less than 8 years of age if it is prescribed? Interesting. Azithromycin, ciprofloxacin, nystatin, or tetracycline? Hmm, that is a very interesting question. Let's try. I'm gonna assume nystatin. Let's see what that says. No, tetracycline. If a female takes tetracycline during pregnancy, the fetus may develop permanent stains on its teeth. Interesting. Okay. Something new that I did not know. Tetracycline's a fairly, I wouldn't say a new drug, but I know that we did do a lot of IV tetracyclines back when I was working in the hospital IV room. But prior to then, I don't even remember that being a PO drug. So, yeah, interesting fact on that. Second question: a patient has been prescribed MAOI, monoamine oxidase inhibitor, for depression. How much time must lapse after discontinuing a MAOI before a different antidepressant is prescribed? That's another good question there. Um, if you have looked through your medications, you should be able to find that on page. Let me go back and look here. Similar um, conditions of the nervous system, page 15 in your book. Monoamine oxidase inhibitors on page 17 in your book. Adverse reactions, postural, hypotension, dry mouth, constipation, urinary retention, and blurred vision. And this one's saying when you should stop and start again. If a physician changes therapy, MAOI should be discontinued for 2 weeks before new therapy begins. So on page 17 on the bottom on the comments, it does let you know 2 weeks, which is 14 days. All right. Moving on, which of the following conditions is enoxaparin indicated? Is it deep vein thrombosis, prostate cancer, pulmonary hypertension, ventricular tachycardia? So that's going to be in your cardiovascular, and that is on page Central nervous agents. Let's look here. Vasodilators, maybe. No. Cardiovascular starts on page 26, and we are looking for enoxaparin. Digoxin. Let's see here. Enoxaparin. And that should be with the warfarin, I think, and heparin, anticoagulants. There it is, and under anticoagulant. And which of the following conditions is enoxaparin indicated? Indications: stroke prevention, atrial fibrillation, and preventing thromboembolisms. So on page 33 under anticoagulants. Um, let's see which one of those. Deep vein thrombosis, no. Prostate cancer, it wouldn't be prostate cancer. Pulmonary hypertension, no. Ventricular tachycardia, let's go with A. Yep. Enoxaparin is indicated for deep vein thrombosis. So, preventing thromboembolism would be your answer on page 33 under indications under anticoagulants. So that's why you got to keep studying here with your medications. Candesartan is the generic name for candesartan. So sartan that is dealing with lipids, so glucose. Candesartan, that would not be Celebrex. Celebrex is celecoxib. Cleocin is clindamycin. So it's Catapres or Altecan. And Catapres, I believe, is clonidine. So Altecan, I believe. Yeah, and it has a little bit of CAND here. CAND, kind of a way to remember. Candesartan is generic name for Atacand. Clonidine is generic name for Catapres. Celecoxib is a generic name for Celebrex, and clindamycin is a generic name for Cleocin. All right, moving on. Which of the following is a adverse effect for males being prescribed spironolactone? Spironolactone. I'm gonna have to look up that one because I don't know. I'm thinking this is dealing with your hormones. Adverse effect. So I'm gonna look back here in the index and see what page spironolactone is on. Hopefully I can find it. It's 32T, 37T. Let's look at 32T and 37T. Um, Spironolactone is a diuretic. It's showing on page 32. Oops, plug in my battery here. And let's see, adverse reactions, postural hypotension and possible hypokalemia, depending on the agent used. Hypokalemia. So it'll take your potassium. Let's see if it says anything else. Doesn't look like it. Let's look on page 37, like, see what it says over on page 37. All right, potassium-sparing diuretics, spironolactone, aldactone. Hyperkalemia, renal impairment, anuria. Should be avoided in patients taking angiotensin-converting enzymes. Inhibitors owing to potassium-sparing effect. Avoid salt substitutes. Avoid grapefruit juice. Diuretics should be taken early in the day. But it does not say anything specific in regards to males being prescribed spironolactone. Males taking spironolactone may develop gynecomastia. And I don't even see that on any part of it. Interesting. Oh, there it is. Adverse reactions on page 37. Um, Under potassium sparing diuretics, hyperkalemia, arrhythmia. So it's not hypokalemia, it's hyper. So it wouldn't have been that one. So gynecomastia. And I believe that's like enlargement of the breast, I believe. All right, moving on. We found the answer. Number 6, which medication is indicated for hypothyroidism? So we're looking at for something that's for the thyroid. Let's look at levothyroxine. Levothyroxine is Synthroid. Synthroid is the brand name. It's indicated for hypo, which is, less or decrease in thyroid. Both methimazole, which brand name is Tapazole, and propylthyrosol, PTU, are indicated for hyperthyroidism. And calcitrol, brand name Rocaltrol, is indicated for hyperparathyroidism. And you should be able to look those up under the hormones in your medications in chapter 1. That should be listed under the hormones um, aspect of it. So make sure you still are going through these um, medications. Which term encompasses the absorption, distribution, metabolism, and elimination of a drug? So was that pharmacokinetics, pharmacognosy, pharmacology, pharmacopoeia? Pharmacokinetics, of course. ADME, absorption, distribution, metabolism, and elimination. All right. A patient has been prescribed a fentanyl patch for severe chronic pain. How often should the patch be changed? Usually it's a 72-hour dose, so every 3 days would be proper. Number 9, which of the following is an example of a beta blocker? So let's go back and remember they end in what? Do they end in OLOL or do they end in PRIL? If you knew what the suffix was, it should make it easier for you to know which one to pick. So if you did study, you should and know that beta blockers end in OLOL. Metoprolol, which is Toprol XL, brand name, is a beta blocker. Candesartan, Altecan, is an angiotensin 2 receptor antagonist. Enalapril is an ACE inhibitor. They get in pril. Sartan are ARBs. And spironolactone, or brand name aldactone, is a potassium-sparing diuretic. So if you have not gone through your um, cardiovascular meds, please get through those. This is all under the cardiovascular section. Number 10, which of the following is an example of a class 3 antiarrhythmic medication? So let's go look at what antiarrhythmics are in your book here. See if I can find it. Class 2 Antiarrhythmics. Class 3 Antiarrhythmic Agents. Page 28 in your book. Um, so you have your amiodarone, dronedarone, sotalol. So which one was it? Dronedarone. Okay. So you would find that on page 28. So, after that, hopefully you give yourself a test and see which ones you do remember. But you need to be doing this on a regular basis, or it's not going to help you out. So just please find ways to help you remember how to study for these different questions from about medications. It'll help you out in the long run, especially if you're going to, go further into your careers through pharmacy or whatnot. So, Jonedrone is classified as class 3 antiarrhythmic. Lidocaine is a class 1B. Propranolol is a class 2. And verapamil is a class 4 antiarrhythmic medication. So, I mean, you would have to go through, your cardiovascular section to know that and test yourself, study through these, give yourself 30 questions. We went through these in 30 minutes. So give yourself an hour or so and go through these. All right. All right. Moving on. All right. So again, we go through your medications. We've done federal requirements and we just finished patient safety and quality assurance. For those who did not take the test or are going to retake it, I did open up the um, your test so that you can view it. So if you're not able to view it, if you're going to retake it, please let me know so that I can open it. I'm pretty sure I opened it. Let me make sure here. Yeah, March through March 21st. Which, if you're going to retake it, we can either do it Wednesday or next Monday. I will I'll leave that up to you on that. All right. All right. Moving on to chapter 4, order entry and processing. So we've learned federal requirements on certain aspects of pharmacy, um, working in the pharmacy, what they keep in track of. Very, they are very strict with control to medications. You really want to triple count those medications, and a lot of the times the pharmacist is the only one handling those medications. Okay. Um, Also, this is going to get you started in the skills process. You're going to understand the difference between the community setting and the hospital setting, which is institutional setting. There's big differences between both of those. They are not the same entity, although they follow under a lot of the same laws. But you'll find different. There are different aspects to both of those entities. Okay. Order entry processing, pharmacy technician certification exam. This is going through the PTCE. Well, and then you got GXCPT here. So basically, this is where the skills portion um, will help you. You'll learn different parts of the skills portion. Dispensing, overviewing laws, and dispensing processes here. Um, oops. So, we have started pharmacy calculations. And if you have not looked through any of the pharmacy part, you might want to because you have to really understand your Roman numerals. Okay. So we're back here. And, you know, this is why I gave you that kind of information early so that you can test yourself. So, again, um, these are the things that you might need to know. A lot of the times, the pharmacist will be the one to calculate, but there's times that you may have to. And there's different conversions. You have to understand your Roman numerals. You have to understand temperature conversions. I have yet to do anything in regards to temperature conversions, but it's good to know. And I believe it's could be chapter. I'm not gonna lie to you. I don't really remember which chapter it was on, but I think it's before chapter 20. But I will look back and well, we will look back here just a moment. Again, you have to know your different types of metric household apothecary conversions. Understand 1,000 milliliters. Um, we're not so much geared towards the length, but more so the weight and volume. So understand that 1,000 micrograms is 1 milligram. 1,000 milligrams is 1 gram. 1,000 grams is 1 kilogram. And understand that 1,000 milliliters is one liter. 2.2 pounds is 1 kilogram. And here are different conversions here that I have given you already from that sheet. Understand that 5 mils is 1 teaspoon. 15 mils is 3 teaspoons, which is equal to 1 tablespoon. 2 tablespoons is 1 fluid ounce, which is 30 mils. 8 fluid ounces is 1 cup. 1 cup is 240 mils. 2 cups, which is 480 mils, and that's 1 pint. 2 pints, that's 960 mils, and that's 1 quart. And I can't, what's 4 times 960? 2,800 and something. Maybe it'll tell us down here. 4 quarts is 1 gallon. Mm, I don't know. You have to do that on your own. 960 times 4. All right. So again, here's some more apothecary systems. Have to understand. I don't know about the scruple. I've never seen much on the scruple. I know 1 dram is 5 mils, which is shown here, right here. And let's see what else is it asking. 12 ounces is 1 pound. 8 drams is 1 ounce. Not too much focus on that weight unless maybe you're compounding. Volume, 8 fluid drams is 1 fluid ounce. And we know that 1 dram is 5 mils. So if we have 8 of them, that's 40 mils. Um, yeah, you're gonna have to get to know these. Um, so if you're having questions on certain um, conversions, this will help you out. All right, that's units and milliequivalents, reducing and enlarging formulas. Percentages and strength of medications. And we are doing that through the math. Concentration and dilution. Allegations, that's further on down. Hopefully we'll get to it. Those are pretty easy to do. Allegation medials, specific gravity, calculating doses. We kind of started doing that. There's different calculations for children's doses, like the Clark's rule, the Young's rule, Freed's rule down here. Body surface area method. My high school students just got through doing this, and we're about to take a test. I believe it's chapter 27, if I got it up there yet. Chapter 26 or 27 on this, on in the math. Terminology, y'all been going through that stuff, so make sure that you understand what goes to what. Cardio goes to heart, derm goes to skin, gastro, stomach. You got to understand these type of things when you're reading your prescriptions. The pharmacy abbreviations, y'all got a head start on that. Um, Keep on going through them. And it's also stating Appendix G is going to help you out. So make sure that you are going through that. What else? Medical abbreviations, which you probably can Google or ask AI. Pharmacy technician tasks. Pharmacy technicians are permitted to perform a wide range of tasks during the order entry and prescription filing process. Some of these tasks include accepting new prescriptions from the patient, receiving prescription refills from the patient, requesting refill authorization from the patient prescriber, collecting patient information, maintaining patient profiles, entering patient, prescriber, and medication information into the pharmacy's information system, interpreting the prescription's SIGNA, billing prescription to third-party prescription providers, counting and pouring in correct medication, labeling prescription bottles, returning medication bottles to the pharmacy shelves, repackaging the medication, preparing unit dose medications. Prescription filling process. Again, when we start the skills, you'll have to look at the prescription and make sure it's a valid prescription, not a fraud prescription. What's noted on the prescription is the prescriber's information. You also want to make sure that the date of the prescription was written and the patient information, like the patient's name, address, phone number, um, zip code, all that stuff. The description, understand these different types of names here: inscription, subscription, signa. Inscription has the name of the medication, the strength of the medication, the dosage form, and the quantity of the medication to be dispensed. That's the inscription. The subscription is the instructions to the pharmacist. The signa is the directions to the patient. Okay. Signa is usually what we have to decipher. That's in abbreviations. Understand that check to make sure there's any refills. If a doctor puts like PRN refills, they are able to get refills according to how many days it should last. So if you do get PRN refills, that's like having refills for a year. And depending on how long they last, I mean, they could last for 30 days and then they can get another refill, or they can last like maybe 15 days and then they can get another refill. They usually try to wait at least 3/4 of the time that's passed to make sure that they're able or eligible for another refill. Also, make sure that the physician's signature must be in ink, handwritten in prescriptions. Stamped signatures are illegal. So it should look like something like this. Substitution permitted. So it's allowed that generic is permitted. So you'll put down this date here. Of course, if they pretty say that this is an expired um, dated prescription, but if it said 12/12/25, then or 12/12/24, then it's still valid. It would be valid until 12/12/25 or 12/11/25, I would say. All right, moving on. So make sure that it looks authentic. Make sure it has all the information needed, and if it is a narcotic, got to make sure there's a DEA number, and you want to make sure that it is valid. Is this one valid? ABA, ABF, MRX, yep. Uh, Doctor's name's Dr. Crumb, that's okay. So 1 plus 4 is 5, plus 1 is 6. So 2 plus 3 is 5, plus 7 is 12. 24 plus 6 is 30. That last number is 0 in that 30. So that is a valid script or valid DEA number. You will have to read what this deciphers. And remember, you always have to start with a verb. Take one tablet daily. Take one tablet daily. How do I know that's a tablet? Because right here. And you will pull the one that says that is a tablet that's on your shelf. Okay? So you will take one tablet daily. You'll put a quantity of 30, refill 6 for the patient Billy Jones. Um, Usually we'll try to get the date of birth of the patient just to make sure we have the right patient. All right, moving on. Required medication and order information. Um, Prescriber's information, including the physician name, DEA number for controlled substances only, and the hospital assigned ID. See, it's got an ID up there. Yeah, license number. Date of the order, patient information, including the room number, bed number, and ID number assigned to the patient. That is more like on a hospital order, it would seem like. Name, strength, and dosage form of the medication, when to be administered, which is the frequency. In some hospitals, the frequency is assigned a specific time. The duration of the therapy and prescriber's signature. So that would be more in the hospital setting there. I don't know, they have an example of that. Patient profiles. The patient profile provides the patient's health history. It is to be completed the first time a prescription is filled in the pharmacy and updated with subsequent new prescriptions and refills. Required information for a patient profile includes patient information, name, age, sex, race, address, and age of patient. Obtaining the telephone, home, mobile, or work numbers of the patient is highly recommended, just in case, if the insurance does not go accept it, we can call them and see if they got any other insurance. Billing information, again, third party provider or insurance. Medications the patient is taking. You want to keep that updated. Make sure that, if it's a new patient, you want to get his what other medications the patient is taking, whether it's prescription OTC, vitamins, herbal supplements. Um, any allergies, medical history to include surgeries, disease states, or health conditions, adverse drug effects, the patient has experience, and drug and allergies. Any medications or allergies the patient is known to possess. This information is necessary to ensure that the patient does not receive a medication that can have an adverse effect on the patient. So we want to make sure that all that information is inputted in the patient profile. Types of prescription medication orders. Again, this is more towards your hospital setting, STAT, ASAP, and PRN. STAT meaning a medication order that should be filled within 15 minutes of receiving it in a hospital. ASAP, as soon as possible. A medication order that does not have the priority of a STAT order but needs to be processed as soon as possible. And PRN is as needed, an order that may be filled or administered when a patient requests it, but there may be limitations associated with it. Methods of receiving a prescription, whether it's a walk-in, call-in, e-prescribing, or fax. Prescription refills. We went over this in law, federal requirements. Schedule 2 controlled substance prescriptions are not permitted to be refilled. The patient must obtain a new prescription from the prescriber. Schedules 3 and 4 controlled substance may be refilled if authorized on the prescription. However, the prescription may only be refilled up to 5 times within 6 months after the date of issue. After 5 refills or after 6 months, whichever comes first, a new prescription is required. The number of refills must be indicated on the prescription for non-controlled substance prescriptions. Refills for non-controlled substance prescriptions are valid for 1 year from the date of issuance. A PRN refill for a non-controlled substance prescription may be refilled as needed up to 1 year from the date of the prescription being issued, as I was letting you all know earlier. Refilling a prescription, the following information should be obtained from the patient when they call in a prescription refill. So you want to ask for the name, contact information, date of birth, the telephone number, prescription number, and the name of the medication, strength, dosage form, and quantity. If the patient does not have all this information, the patient's profile can be accessed by the computer by the patient providing his or her name and date of birth. If the prescription does not have any refills remaining, the pharmacy technician may contact the prescriber by telephone or fax or electronically. Moving on to data entry, interpreting the prescription. So this is where it's vital, where you have to understand um, what to write in when you're doing data entry, and you always want to start with the verb. That's first and foremost. All right, whether it's take, whether it's instill, whether it's insert, whether it's what other verbs may we use? Swallow, um, apply. So, I mean, it just depends what the dosage form is, okay? So, identify the name, strength, dosage form, and quantity of medication to be dispensed when you're interpreting the prescription. You have to identify the route of administration. Um, Identify the frequency of administration. Determine if the generic drug may be dispensed. That's your DAW codes. Again, DAW code 0, generic is okay to dispense. DAW code 1, um, substitution not allowed by provider. And I'm looking down here, your DAW codes here. DAW2, substitution allowed, patient requested product dispensed. 3, substitution allowed, pharmacist selected product dispensed. And 4, substitution allowed, generic drug not in stock, and so on. And you can go on through these dispense as written codes. These right here are more for your insurance-based purposes. All right. That they may be okay with them dispensing a brand name. It's just that, their price might be increased because it's a brand name. So you just never know. Entering the prescription into the pharmacy computer system. Information required is prompted and quantities are entered in metric quantities. So understand what, metric quantities are. Prior authorization requires a physician to obtain approval from a managed care organization for a specific medication before it is dispensed by the pharmacy. So maybe you'll get a rejection and it says prior authorization required. So you'll dispense whatever it is. No, you won't dispense. You'll fax that information or you'll send that electronically to the patient's doctor, and they will get a hold of the insurance company as to why the patient needs this. Prior authorization is an extra step in the prescription billing process before the insurance company decides to pay for the prescription. Without prior authorization, the patient may be responsible for the entire cost of the medication. Situations may require prior authorization, including the following: brand names medications that have a generic availability, expensive medications with age limits such as Retin-A, drugs used for cosmetic purposes such as Propecia, medications such as Cialis and Viagra prescribed for non-life threatening medical conditions, drugs not usually covered by the insurance company but said to be medically necessary by the physician. Medicines that are usually covered by the insurance company but are being used at a higher dose than normal. So you would send that off to the doctor, and then they would call back and say there's the has been authorized or what, the insurance company or the doctor. Third party adjudication involves submitting a prescription for payment by a third party drug insurance provider. If the prescription drug insurance company denies payment, the patient is responsible for full payment of the prescription unless the rejected claim is corrected and resubmitted to the third party prescription drug provider. Information transmitted during adjudication is the patient's information, the prescriber's information, pharmacy information, and the prescription information. That's all going to and from electronically to the insurance company, back to the uh, pharmacy. Patient's relationship to cardholder, you would need to know this. The patient's relationship to the cardholder will need to be entered. Many plans use the following relationship holder codes. Sometimes cardholder is 00, and sometimes 01. Just depending what your software likes. Usually spouse is 02, and all other dependents go from 03, 4, 5, however many dependents there is. Other information that you may need is that you might need to take down on the prescription when you're getting that information, or you can make a copy of their insurance card and put that all that information on file and staple all that together with the original script so that you can have all that information together so it won't be separated. All right, so you would have to go through all those steps in entering the patient's information and uh, make sure you do get their insurance information. So this is determining primary coverage and co-payment. So if you have gotten prescriptions before, you should know the process. National Council for Prescription Drug Programs, it's CPDP rejection codes. So you will get these types of rejections, and you would have to correct them on whatever's missing, whatever information's missing. Again, here's DAW. Make sure you have the right DAW code. If a prescription has been rejected, it may be resubmitted. Prior to resubmission, all of the rejection codes must be corrected. Um, there's a lot of stuff that I cannot teach you skill wise in regards to insurance. You learn that as you go when you start working doing real prescription insurance information. Again, here's the drug utilization evaluation review. This is over 90. This is what over 90 has us do or has the pharmacist do. Process of verifying the prescription being processed does not interact adversely with other medications on patient's profile. If a warning is observed, the pharmacist is to be notified immediately to determine the proper course of action in filling the prescription, such as contacting the physician or continue filling the prescription. The pharmacist makes a decision based on information on hand, and more in-depth discussions found in Chapter 3, Patient Safety Quality Assurance. Again, that goes back to over 90 with her counseling the patient and making sure there's no adverse effects, drug-drug interactions, food-drug interactions, or anything like that. So now we're going to fill the prescription. Once we've inputted all the information in the computer, we printed out a label, pull the medication from the shelf, and check the prescription label against the NDC number found on the bulk container. Scan the UPC code on the bottle to ensure the correct medication was selected. All right, so normally we would scan. We don't have scanners in the lab, but we would scan the medication to make sure it's right. Usually it'll give you a signal if it's a raw medication and or a warning and to get the proper one. But for the most part, we're going to be matching the NDC number on the bottle with the NDC number on the prescription label. Um, Measure or count the medication. So after you find the right med, you're going to count the medication or measure it out. If counted manually, count in multiples of 5. So usually we count in fives. Whether counting manually or using automatic counting equipment, recount the quantity for accuracy. If any penicillin or sulfa drug is dispensed, the pill counting tray should be wiped down using isopropyl alcohol. So like any sulfa or penicillin was dispensed prior, wipe it down with alcohol because a lot of people are allergic to penicillin and sulfa drugs. When dispensing oral chemotherapeutic or hazardous agents, the pharmacy technician should wear gloves to prevent the skin from coming into contact with the medication, and the counting tray wiped down using isopropyl alcohol. Place a completed prescription container on top of the original prescription with a bulk container that has been pulled for the shelf. So you would put the bulk container behind the little container that you use to put the medication in on top of um, both on top of the medication label. Of course, you would put um, a sticker label on the bottle that you just counted for. Packaging, select an appropriate size container and pour the medication into the container. Place an appropriately sized child-resistant top on the container. If a patient requests an easy open top, have the patient sign the back of the original prescription indicating the request. Or, on the profile, sometimes it'll have you check off easy open container or non-child proof containers only. Container use, there's round vials used for solid dosage forms such as tablets or capsules. Prescription bottles used for liquids and low viscosity. Wide mouth bottles used for bulk powders or large quantities of tablets. Dropper bottles used for ophthalmic, nasal, otic, or oral liquids. Applicator bottles used for applying liquid medications to a wound or skin surface. Ointment jars and collapsible tubes used to dispense semi-solid dosage forms, and hinge lid or slide boxes used for dispensing suppositories and powders. USP classification of containers. I can let y'all read through those. Child resistant containers. Um, the Consumer Product Safety Commission requires drug manufacturer to place prescription drugs in child-resistant containers if the original package is intended to go directly from the pharmacist to the patient. So again, this is back on the Poison Prevention Act. Um, Takes us back to making sure that we keep these out of children's mouths or out of children's hands. All legend drugs intended for oral use must be dispensed by the pharmacist to the patient, having a safety closure unless the prescribing physician or patient requests otherwise. If a patient requests a non-child resistant container, the prescription may be dispensed in a non-child resistant container, but the patient must sign the back of the prescription indicating he or she has requested a non-child resistant container. Usually community setting pharmacies will have a form for them to fill out and see if they want child-resistant containers. Medications exempted from the child-resistant containers include sublingual dosage forms of nitroglycerin, sublingual and chewable forms of isosorbide dinitrate in dosage forms of 10 milligrams or less, erythromycin, ethyl succinate granules for oral suspensions and oral suspension in packages containing not more than 8 grams of the equivalent erythromycin. Erythromycin ethyl succinate tablets in a package containing no more than the equivalent of 16 grams of erythromycin, and so on. I'll let you read through those. Drugs that are used or dispensed in a inpatient institution, which is a hospital, nursing home, or extended stay facility, are not required to be in child-resistant containers. So this is drugs that are used or dispensed in inpatient institutions. A little bit more on labeling. Place the labels on the container and the upper backhand corner of the original prescription. And also understand what prescription label requirements are needed, date when the prescription was filled, serial or prescription number, RX number of the prescription, um, name and address of the pharmacy, name of the patient, name of the prescribing physician, all directions for use of the prescription. Um, Generic or brand name of the prescription, strength of the medication, name of the drug manufacturer, quantity of the drug, expiration date of the prescription, initials of the licensed pharmacist, and number of refills allowed. All right. Well, that's all that needs to be on the label that you print. Moving on here. So here's an example of a label. Would have the prescription number, prescriber name, patient name. So when we print out labels and stuff, do the skills, you'll see how that goes. And again, medication label requirements here. Name and location of the patient, trade or generic name of the drug, strength of the drug, quantity of the drug for the outpatient prescription labels, expiration date of medication, and lot number of the medication. Sterile product label requirements. So this is whenever you are doing making IVs or whatnot, sterile product compounding. This is all that's needed in that on that label. And sometimes you'll do unit doses. You'll do a lot of unit doses in the hospital. We'll do probably repackaging and bubble packaging in the uh, community setting, where we bubble package for nursing homes. So that type of information is needed on that. All right, manufacturing drug labels. Again, it goes back to National Drug Code or the NDC number, which is a 10 or 11 digit number composed of three segments, where the first four to five numbers are indicate the drug manufacturer. The second four numbers indicate the drug entry, and the last two numbers are the drug package. There's also a lot number, which are assigned by a drug manufacturer to identify a specific batch of medications. And that's vital because if there's a recall, we can go back to that lot number, to that specific one, that specific batch to pull all those that were affected. Expiration dates are assigned by the drug manufacturer, who guarantee that the medicine is fully potent and safe to take based on the product testing up until that date. Here are some common auxiliary labels that you would place on a prescription. For suspensions, shake well. For ophthalmic preparations for the eye. For aortic preparations for the ear. Ointments, creams, and lotions for external use only or for topical use. For suppositories, you'll have for rectal, for vaginal use, and patches apply to skin. All right. Patient package insert requirements. A patient package insert is an information leaflet written for the lay public describing the benefits of the risks of medications. Pharmacy is required to provide patient package inserts to all patients receiving metered dose inhalers, oral contraceptives, estrogen, progesterone, and isotretinoin. Keep those in mind because you might um, get a question on that, on package inserts and the requirements. Medication guides. FDA requires the medication guides be issued with certain prescribed drugs and biological products when agency determines that. Certain information is necessary to prevent serious adverse effects. Patient decision making should be informed by information about a known serious side effect with the product or a patient adherence to direction for the use of a product essential to its effectiveness. Examples of medications requiring medication guides be provided to the patient, including. So all these types of medications are requiring medication guides here. Patient counseling, again, is geared back to OBRA 90, Omnibus Budget Reconciliation Act of 1990, requires that an offer to counsel is made to counsel every Medicaid patient receiving a new prescription. State pharmacy regulations may require that counseling is made available to every patient receiving a new or refilled prescription. It is the role of the pharmacy technician to ask each patient if they have any questions regarding their medication. If so, the pharmacy technician informs the pharmacist on duty and if the patient has questions. The pharmacist is the only individual who may legally counsel a patient. While counseling a patient about the prescription medication, the pharmacist should ask about any over the counter medications they are taking to prevent unnecessary drug interactions. Over the counter recommendations. OBRA 90 does not require the pharmacist to counsel a patient when they are purchasing an over the counter medication. OTC recommendations should be made by the pharmacist, not the pharmacy technician. Durable medical equipment, or DME. Examples of durable medical equipment include walkers, wheelchairs, hospital beds, prosthetic devices, orthotics, home dialysis supplies, and surgical supplies. Usually, when we're dealing with Medicare, we believe Part B, we are dealing with DMEs or durable medical equipments. Automated dispensing systems. Pill counting system has are used to accurately count tablets and capsules for individual patient prescriptions. Automated dispensing devices are located in hospital patient care units, surgical suites, emergency rooms, long-term care facilities, physicians' offices, and other settings. This one's a pill counter that some um, community or retail settings may have. They'll scan the barcode right here, and this will pop up. They'll have the name of the drug, what the drug looks like, the pill, and then you'll start pouring, and it'll start counting for you. Um, these are for high quantity medications, that require 540. Sometimes you have to count to 960, depending, how long it'll last. 90-day supplies. There, it's counting there. And then you can pull that up or pull that out, and you can put it in the container. So read up on features of the automated system, advantages and disadvantages of the automated dispensing system. Increased safety, accuracy of perpetual inventory, automated ordering through minimum maximum parameters. Analysis can look for increase or decrease in demands. Can have daily restocking, top ups, paperless, automated narcotic control, drug control, improved time management for pharmacy and nursing staff, and improved workload and time. It's time effective. Really, it is time effective. You have one of those because counting by fives, 960 pills takes a little bit. Moving on, disadvantages of automated dispensing systems include requires highly trained staff for implementation, for training and maintenance, expensive to purchase and maintain. That's why you don't see many in the retail setting because it's expensive. And which, I mean, big pharma, come on, it's expensive. All these big chains, it's not expensive. They just want you to work. Difficult to implement across the authority. Policy and procedure changes for staff and can lead for staff frustration. Sometimes if it does not work. For the most part, if you have a IT genius around, usually things go pretty smooth. That's the next thing you might want to consider is getting into IT because we do a lot of IT work sometimes, to fix things, to make things keep things flowing. All right, so I would look over all that advantage and disadvantages of ambulatory care automation, um, centralized and decentralized inpatient automation. Look over those. Automatic dispensing in a community system. So some pharmacies who are very busy might have baker cells, and these will hold bottles and bottles of maybe your top 10 to 20 medications, your fast movers, and you'll fill those baker cells or Kirby's or Script Pros or Paradas, and it'll automatically count for you that specific drug that you printed a label for and whatnot. Only thing is that you probably have to scan, and then you have to um, pour it in there and all that. So that's what they'll need you for the most part in regards to um, quick accessibility, and patient safety and accuracy in counting the correct amount, especially large amounts. Automatic dispensing in a hospital pharmacy. Just one moment. It looks like. All right, so automatic dispensing in a hospital pharmacy. Examples include the Pyxis and OmniRx. We will refill these for the nurses and for each individual unit that has a Pyxis or OmniRx. Um, and we will make sure that the barcode is scanning correctly and whatnot. Keep the par levels a certain amount as to how many they use per day and whatnot. And we have to go back up there and check for expiration dates and whatnot. So, if I was to choose which baker cells or which automated dispensing systems to use, the hospital setting may be a little bit more hectic because we might have to create barcodes for certain medications so that they're able to scan. All right. So go over the non-automatic dispensing systems in a hospital pharmacy. Um, says procedures for identifying medications and supplies. Let's see where I'm at here in the book. So where are you? On page 156. We've gone through pretty detailed amount. On 156. Actually, 158. We're on page 158. And I'm trying to see how much further there is. That's about halfway through. So I'm gonna um, come to a close here and get into some math. Um, there's certain questions that were asked on chapter 14, and let's go into there. All right, so you find your math here. All right, chapter 14. So adjusted refills for short fill prescriptions. These are good. Sydney requested a little overview of this. So, the amount of medication a pharmacy can dispense to a patient is restricted first by the prescriber's guidelines and second by the insurer's guidelines. Calculations are often needed to adjust first the quantity dispensed to comply with the insurer's guidelines and then the number of refills allowed. Pharmacy technicians often need to accurately estimate how long a medication will last with adequate guidelines. Estimating day supplies, especially tricky when the dosage form is a lotion, cream, ointment, or inhalant. When dispensing medications that come in handy convenience packages or dosage packages such as methylprednisolone, estimate the day supply when you have the package in your hand so you can visually examine how it is packaged and read from the labeling or package insert how long the contents of the package should last. Usually, it is inappropriate to disrupt the packaging for medications that come in inconvenience packages or dosage packages, as well as nitroglycerin products that are packaged in glass containers. Third-party programs often have dispensing limitations that are less than the quantity of medications that has been prescribed. So example 14.1, a prescription is written for Prozac 20 milligrams, number 50, one cap daily, three refills. The insurance plan has a 34-day supply limitation. So they'll only pay for 34 capsules because the patient's only taking one capsule daily. How many capsules can be dispensed using the insurance plan guidelines? And how many refills are allowed with the adjusted quantity? Calculate the total number of capsules allowed by the prescriber. So we have 50 capsules, four total refills, counting the first one. We have four refills. Well, the prescription says three refills on the bottom left-hand corner, right? So that you would input that when you're about to print your label. So you'll give them three refills, but you're gonna since you got to calculate it for a 34-day supply, you want to know how many total capsules you're going to start off with. Okay, so there's a four total fills, including with the inclusion of this script. So we have 50 capsules times four refills, which gives us a total of 200 capsules. Keep in mind, four total refills is the original fill plus the three refills. Okay, that's why we multiply that times four. So you have a total of 200 capsules. Okay, so then you use the dimensional analysis to calculate the total number of fills for capsule 34 capsules allowed. Okay, so you have um, one fill is 34 capsules because that's how much the insurance will allow, right? And we want to know how many more refills they can get, right? So I would actually start out with fill over capsule equals to 200. And so you're going to you cross out. Well, let me see. Oh, let me see if I can put this. Well, no, I won't start that part till I get to a one that I'll work on here in just a bit. Anyways, I would start off with since I'm looking for fills or how many refills. One fill is 34 capsules, so I'll put one fill equals to 30. One fill over 34 capsules equals to 200 capsules over X. So then now you're going to cross out capsules from the top and the bottom, and all you're left with is with fills. All right. So you're going to divide 200 divided by 34. And let me see if I can calculate it here. 200 divided by 34 equals to 5.88 refills. So that's what they have. It has 5.88 refills. All right. The original prescription will have 4 additional refills of 34 capsules plus 1 refill of 30 capsules. That's how they calculate it because of insurance purposes. All right. So let's look at this example here. Prescription is written for Donato Elixir 1 pint. And the I guess the instructions are 1 teaspoonful at HS plus 1 refill. 1 teaspoonful at bedtime plus 1 refill. And 1 pint is what? 473 mils. The insurance plan has a 34-day supply. So 1 teaspoonful, which is 5 mils. So 5 mils times 34. 5 times 34 equals to 170. So since the insurance will only pay for a 34-day supply, they can only dispense 170 mils of that 473 out of that 1 pint. All right. So 1 pint, well, I calculate the total volume allowed by the prescriber. So you have 1 pint and 2 refills. Okay. 1 pint times 2 refills. Yeah, because we're including the original plus the 1 refill. So you only have 2 pints. So that's a total of 946 mils. We calculated the day supply for 34 days, so that's 170. So we have a total of 946 mils, and 1 fill is 170. So I will again start off with fill over 170 mils equals to 946 mils over X. And your mils cancel out, and you divide 946 divided by 170. Where? Okay. 946 divided by 170 gives you 5.56. So you'll have 5 refills of 170 mils, and then you'll have 1 refill. So 5 times 170. That's equal to 850. 946 minus 850 gives you 96 mils. Or you could have multiplied that 0.56 times 170. Or 170 times. Come on now. 170 times 0.56. So about 95 mils. And that's how you would get that or apply those refills. Let's look at this one. A prescription is written for Celebrex 200 milligram capsules, number 100, 1 cap daily with no refills. Insurance plan has a 21-day supply limitation. How many capsules can be dispensed using the insurance plan limitations? So a total of 100 um, um, capsules total. one fill is 21 capsules because the patient can only get a 21-day supply. So we're going to divide 100 divided by 21. So 4.76. So right here, we got 4.76. So you can refill a total of 21 capsules 4 times, and then 21 times 0.76 equals to 16 capsules, another 16 capsules. So that last fill would be for 16 capsules. Yeah, and the insurance is getting us anything. This is a good one. How many bottles of insulin should be dispensed per fill if the prescription plan has a 34-day supply limit? So the doctor has written Humulin RU100, 2 bottles, and the SIG is 18 units 3 times a day. So for as far as Humulin or insulin, that U100 um, means 100 units per mil. And it's usually a 10 mil vial, usually. Sometimes they go in 3 mils, dispensing, depending on the strength. That might be a U300 or something like that. That's 300 units per mil. So this one in this case is 100 units per mil, 10 mil vial. So we would set this up dimensional analysis. So in one day, we're going to take 3 doses. That's 3 times a day, right? That's 3 doses in one day. One dose is 18 units. All right. And we have 100 units per mil. That's a concentration of the insulin. And then we have a 10 mil. 10 mils is equal to 1 bottle. So now this is set up in dimensional analysis. So you can cross out your doses, you cross out your units, you cross out your mils, and you're left with um, days and bottle. So you'll multiply 100 times 10, which gives you 1,000, and you'll multiply 3 times 18. 3 times 18 equals to 54. Remember that. And we had 1,000 units, or 1,000, we had to divide that by 1,000, or 1,000 divided by 54, which gives us 18 days per bottle. Because each bottle lasts 18.5 days, 2 bottles could be dispensed to cover a 34-day period. So, I mean, you can't take insulin out of that bottle. So you're going to dispense 2 bottles for that 34 days period. All right, let's see if we can figure these out here. So we have metoprolol tartrate 50 milligrams. We have a quantity of 180 and one BID for 3 refills. So calculate the amount per fill allowable if the third-party plan covers 34-day supply and adjust the refills. All right. So basically, we have 180 that we can fill. So what's 180 times four? Four because the original script plus the three refills here. So 180 times four gives us a total of 720. I'm gonna say tablets. All right. So we can only do a 34-day supply. The patient's taking it one, two times a day. So 34 times two. So it's a total of 68. All right. So one fill over 68 equals to 720 over X. So we're going to do 720 divided by 68. And you have 10.58 refills. You could even round that up to 10.6. I, I would. 10.6 refills. So zero point 0.6 times um 34, no, 68. That's just another 41 tablets. The partial would be 41. So the quantity would be um 68 refills, 720 divided by 68 equals. So you would put 10 refills here. And the partial, you're just going to put 0.58 times uh, 68. 39.44. I just give them 39 here. So 68, 10 refills, partial is 39. Let's see if we got that right. Mm, Sorry, ladies and gentlemen. Going for an hour and 41 minutes. I was just checking. All right. I was gonna check, see if this was correct. Go back here. 68, 9, and 40. Huh, 68, 9. What must be 9? It's 9 because we used the first field as 68. So that's why it would be 9 and 40. Divide 40 divided by 68. So what that gives me. Yeah, that's at 0.58. Okay. So that's where they get that. They rounded it up, I believe. So that's where they get 40 from. But yeah, it's quite of an extensive uh, look over, but we do have to make sure that we do get it right because we want to give the best service possible to the patient. The second one, Atrovate inhalation solution, 0.202%. 2.5 mils is the total mils of the inhalation solution times 25 vials. Oh, each vial is 2.5 mils. Dispense 10 boxes. So if we dispense 10 boxes, that's a total of 250 vials. And the instructions are one vial, QID, two refills. So 10 boxes, that's a total of 250 vials. And two refills. So we're going to do 250 times 3, which gives us 750. All right. That's a total with the original fill and the two refills. Total is 750 vials. All right. And we're using one vial 4 times a day for 34 days. So 34 times 4. So 136 vials. But we can't break the box in half. So that's what 4 boxes is 100, 5 boxes is 125. So you're gonna probably have to dispense 6 boxes so you don't have to break a box to meet this quantity. 6 times 25 is 150. So to meet that, you need to dispense 6 boxes. All right, so you're going to be using for one fill, it's 150. All right, so you'll divide that by 750. So that's a total of five refills, which is going to be quantities 150, refills for partial 0. Let's see if we did that right. Yeah, 5 boxes, 5 and 0. So they only want to give you dispense 125, which gives you 5 refills. Would increase that refills to 5 um, with 0 extra. What's that? Well, zero partial. Insulin, Levemir U100 insulin, 10 mils, dispense 4 vials. 20 units daily with 3 refills. All right, so the patient is taking 20 units daily. That's all the patient is taking. Again, each vial is 100 units per mil, and there it's a 10 mil, so each vial has 1,000 units. Okay, so that's 4,000 units. Um, and you still have 3 refills, so that's a total of 1,200 units. All right. So let's figure out how many per day we can use. And keep in mind we cannot break the bottle. So 34 days supply times 20 units. That's a total of 680 units for one fill. All right. So we have total of 1,200, right? 1,200 units because we have 4 vials. It could be 1,600. Hold on. 4 vials or 4,000. Yeah. 4,000 times 4 because it's the original fill plus the 3 refills. So that's 1,600 divided by 680. All right. So the quantity, so we need 680 units. Oh, that's a hard one. Let me think here. Um, 680. So one vial can actually work. So one vial, which is 1,000 units, and we should have a total of 15 refills. Yeah, one quantity, one bottle with 15 refills. Yeah, one bottle, 15 refills. And it gives you some extra insight in regards to different medications, different insulins, and how many day supply that would be. All right. Going through one more and then I will let you go. Ultran 50 milligrams. Number 120, one BID, one refill. So total of 120. Um, original plus one. So that's a total of 240. All right. And patient's taking one BID. So 34 times 2, 68. 240 divided by 68. Okay, so your quantity is 68. Your refills drop to 2.52 or 2 0.5, wait, come on now. 0.52 times 68 equals with 35 partial. So 68, 240 divided by 68. So that would be two refills and 0.52 times 68. So two refills, 0.52 times. And 35 partial. See if we got that right. Well, 36 it rounded. So 68, two refills, and it rounded up to 36. Hope this clarified some things here. I know this can be very confusing. This is not as tedious when you are creating um, the label. Usually the system will figure it out for you as to how many refills it'll um, have if you have a certain amount day supply for that. But I am going to be on from 6 to 8. You got any questions? Um, if you have listened to this whole video, um, nobody's going to be counted absent because it is my fault in regards to this. So, kind of a free day. Hopefully, you are utilizing it to your advantage. And again, please be going over your medications because you will see different questions like we saw today earlier at the beginning of class or beginning of this video. So hopefully I've clarified some things for y'all. We'll finish out the rest of order entry and processing on Wednesday and get into some skills after we take the medications test. Let's look at your NHA before I let you all go. Let me see how much time. Yeah, I got 5 minutes. All right, NHA. Again, make sure that you are going and getting into these courses and getting through them. But, all right, so try to be getting through prescriptions and medication order intake and entry and preparing and dispensing prescriptions. 4 and 5 prior to the 31st. Yeah, that gives you 2 weeks. So yeah, prior to the 31st, get through the 4 and 5. And if you want to go ahead and get into 6, because you do have somewhat of understanding of calculations, then go for it. Then we'll have 7 and 8 final, uh, the last two. We kind of went over medication safety and quality assurance already, but we'll review over that. The 319 is the next date for y'all to take up the practice test. So that's in 2 days. Set aside some time, hour and a half, for y'all to do that. Take that second practice test. Third one will be on April 9th. Then again on April 23rd. Then um, May 7th, and then I'll open your last one for the last week that we are there. We'll meet and you'll take your practice test, and then hopefully you'll have been signed up for your um, major test, major certification. Um, we do have to start thinking about when you want to take your certification during the week of May 12th. Let's look here. All right, May 12th through the 16th. That's the last week that we will meet. So, sometime in April, we need to start making payments to your EXCPT certification. And I will go over that with y'all in class as to how to do it. And I think that's it. Just make sure that you are getting through your modules, your quizzes, and get at least through 4 and 5 for the most part within these next 2 weeks. And we'll go over, we've been going over some calculations. Hopefully that's helped you out for this unit here. But for sure get through 4 and 5, and hopefully we'll get through calculations pretty quickly. And we'll do skills as well, um, so that you are hopefully prepared for the certification test. All right. So that's it for today. Hopefully, I've answered some questions, and I will be online in between 6 and 8 to answer any more questions that we may have and whatnot. All right. All right. I guess that's it. You'll have a great day, and we will see you on Wednesday. And again, my apologies. I don't usually miss class, but today I've had to. You'll have a great one, and see y'all on Wednesday. Well, before I stop recording, I'll see y'all later tonight, not on Wednesday. Later tonight, hopefully. Again, this won't count against you if you don't make it tonight. But just a heads up. I will send the link out to everybody, so watch out for that as well. You'll have a great uh, day, and hopefully I'll see most of y'all online later today, 6 to 8. See y'all.